Myelo comes from the Greek myelos, meaning marrow. A myeloid neoplasm, then, is an uncontrolled proliferation of cells in the bone marrow. Specifically the myeloid lineage, which includes red blood cells, megakaryocytes, which produce platelets, monocytes, and granulocytes, such as neutrophils, eosinophils, and basophils. The lymphoid lineage, on the other hand, are your B and T cells. Don't you worry about those just yet. Lymphoid neoplasms will be covered later on in the unit. For now, focus on abnormal proliferation of myeloid lineage cells exclusively. To illustrate this, we're headed to the MoMA, the Museum of Myeloid Art. Look, I know what you're thinking. Myeloid art isn't real art. Look, I just blew my nose. Is that art? Durr. Obviously, you need a little lesson on myeloid theory and appreciation. In fact, I guarantee that after I give you a little tour, you'll never look at myeloid neoplasms the same way again. Take a look at the sign above the museum. Since this entire sketch is going to involve overproduction of the myeloid cell line specifically, we've incorporated a myriad of cell colors into the museum facade. That's red for RBCs, blue for basophils, pink for eosinophils, white for neutrophils, and tiny white dots for platelets. Of course, it can't be that simple. And there are actually 3 subcategories of myeloid neoplasms to keep in mind. First up, AML. Acute myeloid leukemia is caused by the abnormal proliferation of immature myeloid progenitor cells, called myeloblasts. So, for AML, think of these immature blasts of spray paint made by this punk over here. Those irregular splotches of paint are going to be our recurring symbol for immature cells getting pumped out into the circulation before they're fully formed. And because AML specifically involves the precursor to granulocytes, we've made the splotches blue, white, and pink to remind you of the basophil, neutrophil, and eosinophil progenitor cell. So remember, all those myeloblasts you see in the peripheral circulation of a patient with AML are granulocyte precursor cells that never matured. Though, is it really his fault, or did society let him down? You be the judge. Contrast this with the more mature art down below. Liechtenstein. That's more like it. An overabundance of mature cells in the circulation will be depicted by an array of perfect circles. Overproduction of one or more mature myeloid cell types is the hallmark of our next group, the myeloproliferative disorders. This subset includes chronic myelogenous leukemia, polycythemia vera, essential thrombocythemia, and primary myelofibrosis. To remind you of chronic myeloid leukemia, or CML, let's bring out a grandfather clock, our recurring symbol for chronic disease. Notice, too, that the circles in this painting are blue, white, and pink for basophils, neutrophils, and eosinophils, respectively. Yep, all granulocytes. CML is characterized by the uncontrolled production of mature and partially mature granulocytes. In other words, unlike in AML, these cells make it past that myeloblast phase. Well, most of them anyways. Out in the circulation, you'll mostly find more advanced granulocyte precursors, such as promyelocytes, myelocytes, and metamyelocytes. Look for lots of neutrophils too. CML is caused by an abnormal bone marrow stem cell that has acquired the BCR-ABL fusion gene, which creates a constitutively active receptor tyrosine kinase. This is depicted over on the shipping container. Breakable stands for BCR-ABL, while the tire bumper represents an overactive tyrosine kinase. The chromosome created by the BCR-ABL fusion gene is known as the Philadelphia chromosome. All the myeloproliferative disorders, in fact, are caused by a bone marrow stem cell gaining a constitutively active tyrosine kinase. In polycythemia vera, essential thrombocythemia, and primary myelofibrosis, instead of a BCR-ABL fusion protein, it's JAK2, a tyrosine kinase that resides in the cytoplasm. Once JAK2 is constitutively active, cell proliferation goes out of control, as depicted by this constitutively active tire jack, just jacking away. In polycythemia vera, for example, hyperactive JAK2 causes an overproliferation of red blood cells from the marrow, as depicted by the accumulation of red water lilies in this Monet classic. So many red blood cells, in fact, that the blood gets all sludgy, resulting in hepatosplenomegaly, as well as vision and neurological symptoms. Head over to our impressionistic polycythemia sketch for more details about polycythemia vera. Next up is essential thrombocythemia. Again, JAK2 is wreaking havoc in the bone marrow, this time causing excessive proliferation of megakaryocytes, which leads to an increased number of platelets in circulation. Thrombocytosis, in other words. See the table getting set up for the grand opening party? All those plates are meant to symbolize a plethora of platelets circulating around. Notice, too, that the plates are various shapes and sizes. In essential thrombocythemia, not only are there lots of platelets, there are a lot of different sizes of platelets. On bone marrow biopsy, expect to see an increased number of megakaryocytes. Megakaryocytes are large platelet-producing cells with characteristic lobulated nuclei. And in the setting of essential thrombocythemia, these cells are even larger, with nuclei that are even more lobulated. The table setting above the bone-shaped patio is meant to evoke an image of one of these abnormally large megakaryocytes hanging out in the marrow. The dark plates against the cytoplasmic tablecloth illustrates their almost multinucleated appearance. But remember, this is merely a cross-section of one of those wacky lobulated centers. As you might imagine, lots of platelets in the peripheral circulation increases the risk of thrombotic events, including stroke, MI, superficial thrombophlebitis, DVT, and PE. Watch out, though, because patients with essential thrombocythemia are also at increased risk of bleeding. It's not fully understood why, but it might actually have something to do with an associated von Willebrand factor defect. Von Willebrand, as usual, is represented by our sporty von Willebrand logo. The easiest way to make sense of this defect is to imagine all of these extra platelets prematurely using up all of your available von Willebrand factor, which normally binds to platelets during the formation of the platelet plug. The bleeding that ensues usually takes the form of ecchymosis, epistaxis, menorrhagia, and, as depicted by that surprisingly violent toothpick wound, gingival bleeding. Instead of curing the disease, treatment for essential thrombocythemia centers around reducing symptoms. A regimen of low-dose aspirin can be used to reduce thrombotic complications, but severe disease may also require chemotherapy. Aspirin is symbolized by the concierge guy dressed in our recurring aspirin umpire gear, cleaning up all that thrombotic toothpick trash. Check out our NSAID Sketchy Farm sketch for a more in-depth discussion of aspirin's ability to halt platelet function. All right, one last myeloproliferative disease, primary myelofibrosis. Primary myelofibrosis is characterized by prominent fibrosis of the bone marrow, as illustrated by the fibrotic marrow-themed topiary. Interestingly, before the marrow gets all gross and fibrotic-looking, primary myelofibrosis starts with a hyperproliferative phase. Again, it's that pesky JAK2 tyrosine kinase, as well as a number of other potential genes, that gets mutated inside a bone marrow stem cell, leading to the overproduction of myeloid precursors. In the early stages, the bone marrow is actually hypercellular. Inside, you're likely to find lots of granulocytes being made. Hence our recurring pink, white, and blue granulocyte precursor theme. But another major player here is megakaryocytes, those giant lobulated platelet-producing factories we encountered earlier. Notice that we've given this waiter here an overload of drink platters, each platter evoking an image of a megakaryocyte cell, complete with that lobulated nucleus at the center. Upon inspection of the bone marrow, you'll notice that megakaryocytes are increased in number. They look weirder than usual, too. Their chromatin is coarse-looking, and their nuclei more blobby and irregularly lobulated. Instead of the more symmetric lobulations we described earlier, this is called megakaryocyte atypia. The histological hallmark is bone marrow fibrosis, however. For some reason, these abnormal megakaryocytes release growth factors into their surroundings, stimulating the growth of fibroblasts. Over time, collagen deposits accumulate. Collagen, of course, is represented by our collagenous shark symbol. And voila, bone marrow fibrosis. Notice how the fibrotic growth has taken over, leaving no room for flower proliferation. The bone marrow becomes hypocellular, in other words. Not surprisingly, in late disease stage, an attempt at bone marrow aspiration usually results in a dry tap. That is, lack of aspirate because there aren't any cells, just fibrotic gunk. Because there's limited space in the fibrotic bone marrow, hematopoiesis decides to pack up and head elsewhere. This is called extramedullary hematopoiesis. In the setting of primary myelofibrosis, cell proliferation starts to take place in the liver and spleen instead. This results in massive splenomegaly. The spleen can even get so big that it crosses the midline. The liver also becomes enlarged. The extremely large spleen can cause a heavy sensation in the left upper quadrant, in fact, represented here by this patron who has something in that pocket of his. He probably got that from the gift shop, right? And if the spleen compresses the stomach, it can cause early satiety. Insufficient blood flow to the super large spleen can lead to splenic infarction, which manifests as acute left upper quadrant pain. I forgot to mention. What I just love about this sculpture is to look at it from a visceral point of view. It serves as a pastiche of the radical. What is he? Sorry, where was I? Yes. A pastiche of the radical avoir movement which threatens to penetrate the exploration of montage element. Hey, what is that kid doing? He carved a skull? And is that a pee-pee? Great. Another night of rubbing off dicks for Ricky. That's, not what it... All right. All this talk about the bone marrow. What about the peripheral circulation? Well, despite extramedullary hematopoiesis attempting to make up for the deficient production of cells by the bone marrow, it's not enough to keep the red blood cell count up, and therefore anemia develops. Anemia is represented here by a patron dressed up in a fashionable anemic white dress. The platelet and white blood cell counts, on the other hand, are more variable. Sometimes the platelet count is high, sometimes it's low. Same for the white blood cell count. So the rest of the installation is composed of a sliding abacus-style contraption, reminding you that white cell and platelet count can shift in variable directions. Extramedullary hematopoiesis causes some pretty funky immature red and white blood cells, actually. When seen on the peripheral blood smear, it's what we in the art business call leukoerythroblastosis. Focus on the blast part of that word. We're talking immature cells here. Look for red blood cells that are nucleated, with varying sizes, aka anisocytosis, varying shapes, also called poikilocytosis, or even teardrop shapes. Those are called dacrocytes. You'll likely spot granulocyte precursors as well, represented, as usual, by the pink, blue, and white splotches. What you're seeing are myelocytes, metamyelocytes, and bands. And that's it for the myeloproliferative diseases. Let's do a quick recap of what we've covered so far. In that top left corner is acute myeloid leukemia, or AML. Look for lots of myeloblasts existing in the marrow, hence the blasts of spray paint. Myeloblasts are granulocyte precursors. Everything down below represents myeloproliferative disorders. It's exactly what it sounds like. You're proliferating myeloid cells, as opposed to lymphoid cells, which are T cells and B cells, if you recall. What's causing all the proliferation? A JAK2 mutation in a marrow stem cell, though other genes have been implicated as well. It becomes constitutively active, and cells start dividing nonstop. In chronic myeloid leukemia, it's BCR-ABL instead of JAK2. In these disorders, you'll usually find more mature cells being created, compared to AML anyways. We tried to convey this with these fully formed circles of granulocyte colors, rather than immature splotches. What kind of cells? Well, in polycythemia vera, it's RBCs, as well as a few other cell lines. In essential thrombocythemia, it's platelets. Look for those ridiculously huge megakaryocytes in the marrow as well. In primary myelofibrosis, all kinds of wacky cells are made. Remember that as the marrow becomes more fibrotic, extramedullary hematopoiesis becomes more prominent, especially in the liver and spleen. This leads to anemia. Also expect lots of immature RBCs and immature granulocytes. In general, patients with myeloproliferative neoplasms have constitutional symptoms that are often severe and consist of fever, night sweats, and weight loss. It's the fatigue, however, that's the most common, and often the most debilitating. A medication that may come in handy when treating myeloproliferative neoplasms is hydroxyurea, symbolized by the hydroxyurea hydro rock fountain. Hydroxyurea is a ribonucleotide reductase that interferes with DNA repair, and thus acts as a cytoreductive agent. It's especially useful for decreasing platelet counts, thereby reducing the thrombotic complications of myeloproliferative disorders that are associated with increased platelet production, including polycythemia vera and essential thrombocythemia. Another promising new therapy is the JAK2 inhibitor ruxolitinib. Notice that JAK, party of two, is getting crossed off the guest list. Recall from our Sketchy Farm Founding Father sketch that a lot of those tyrosine kinase inhibitors end with that -nib suffix. So we symbolize them with a pen tip. A pen nib, if you will. And we're continuing the rock theme here, because of that ruxo prefix. Ruxolitinib is especially useful in polycythemia vera and myelofibrosis, and has been shown to decrease constitutional symptoms, reduce splenic size, and improve anemia. Okay, now that we've gone through myeloproliferative diseases, let's move on to their gross cousin that nobody invited. Myelodysplastic syndrome. This is a disorder of dysplastic and ineffective myeloid cell production, and is most common in elderly men. Notice in the planter back there that we're still in the marrow. And it's the same old story. A stem cell in the marrow gains a mutation. This time, however, we're not looking at the overproduction of mature cells or even immature cell precursors. Instead, what we end up with are a bunch of dysplastic cells. That means red and white cells with weird shapes and sizes, and weird nuclei. Eventually, these cells take over the bone marrow, taking over any room for normal cell production. This results in cytopenia of multiple cell lines, anemia, neutropenia, and/or thrombocytopenia, otherwise known as pancytopenia, symbolized at Sketchy with an empty pan. So keep in mind that the clinical symptoms of myelodysplastic syndrome depend on the cell lines that are affected. Anemia causes weakness and pallor, thrombocytopenia leads to petechiae and increased risk of bleeding, and neutropenia produces recurrent infections. Remember, however, even though in the periphery cell counts are low, if you were to take a look at the marrow, you'd see that it's hypercellular, full of those dysplastic hematopoietic precursors. One of the classic dysplastic cells to look out for is the ringed sideroblast. This is a premature red blood cell with iron deposits in its mitochondria, resulting in the appearance of rings of iron around the nuclei when the cell is stained with Prussian blue. Ringed sideroblasts form because these dysplastic RBC precursors have dysfunctional mitochondria that aren't able to properly utilize iron in the cell. Consequently, iron accumulates in the mitochondrial matrix as ferritin, forming the rings. Remember though, you're going to see all kinds of funky red cells and white cells out in the circulation. This includes macrocytes, spur cells, RBCs with basophilic stippling or Howell-Jolly bodies, and dysplastic white cells. And here's a bombshell. Turns out that all myeloproliferative neoplasms, in addition to the myelodysplastic syndrome we just covered, have a propensity to transform into AML. This is called leukemic or blast phase transformation. Isn't that crazy? This is most likely with CML, actually. As many as 90% of untreated or ineffectively treated CML patients will develop AML. Once one of these myeloproliferative disorders decides to jump to blast phase, treatment becomes extremely difficult, often consisting of chemotherapy and stem cell transplant. That's not all. Each one of these myeloproliferative neoplasms can also end up in a fibrotic phase. That's right, we're talking myelofibrosis, just like in primary myelofibrosis, which we illustrated on the right, next to that fibrotic marrow topiary. Okay, come on. You have to admit, now that we've discussed the myeloid neoplasms, you've gained a little more appreciation for the myeloid arts. Am I right? You're going to love our next sketch then, which takes place in a private art studio up on the roof. Be prepared for some snobbish opinions and pithy commentary as we dive further into modern AML and CML art.